On a Monday morning, I got up, I ran 6 miles, I went and did another CT, walked into a pulmonary specialist office and was told that I had lung cancer, which I promptly told them was an EMR error, malpractice, and I did not have lung cancer. My dad's a lung doctor, I've never puffed a cigarette, and I'm fine.
I have a very special guest with me today. Someone actually who got introduced to me through someone on our board, which was a little unexpected. But then I had the privilege of meeting Shira and immediately wanted to make sure we shared her story. Thank you so much for being on the show, and welcome, Shira.
Thank you, Samira. I was excited to meet you too. Sometimes when people try to introduce me to people, I'm a little bit hesitant and nervous and thinking, uh-oh, is this going to be okay? And I felt like we clicked right away, both being survivors and on our own journey, but overlapping a lot.
Shira, maybe we start there because I think the work you're doing is so critical to the space. But before we go there, do you want to maybe take a step back? You ended up getting a scan that, if I understand right, wasn't really part of standard of care or guidelines. And then fast forward, here we are. So maybe take us back and tell us what happened.
Yeah, exactly right. So my husband and I are in the healthcare investing space and have been for a long time. So whenever anything new in healthcare comes out, we do it, test ourselves just because we find it interesting and it's fun to see where we should invest or look at or any of the above. So when 23andMe came out, 15, 20 years ago, we were the first ones to spit in the little vial. When the Gallery Grill blood test came out for cancer, we've been doing that annually for 6 years. When you had an option to get the full genome sequencing, we did that and paid extra for the cancer panel. So we just kind of have always signed up for everything. So when the full body MRI option came about, we looked into that and signed up. My parents are both doctors. My brothers are doctors. They all discouraged it tremendously, as most physicians do. And I ultimately canceled mine also, not because of my family's discouraging rhetoric around it, but because I'm extremely claustrophobic. And so my husband kept signing me up and I kept canceling, and he would sign me up and I would cancel. And he ultimately won because he's a bit of a bulldozer. And I went and had the full body MRI a year ago, actually this month. And when it came back, it didn't really red flag anything. It came up with some minor findings like nodules on my thyroid, which I knew I had because I have Hashimoto's, as well as a 3.8 centimeter mass in my right lung. But it stated minor finding and to correlate with symptoms. But I had no symptoms. I'm a big runner. I'd run 6 miles that day. I showed it to my dad, the lung doctor. He kind of rolled his eyes because he wasn't that into me doing a full body MRI, and also told me that MRIs are better for dense organs like breast tissue or kidneys or livers, but not for lungs, and that I should do a follow-up CT. I ultimately did do it. I was actually showing my endocrinologist the app from the full body MRI. I was like, look how cool this app is. Look at all my insides. Isn't it neat to see? And he said, you want me to order the full body CT, which I did. And when I got that result, it was a Friday, and they said that the mass had grown from 3.8 to 4.2 centimeters, but again, not to worry because I had no symptoms. And I shared that CT with my father and my girlfriend, who is a lung radiology specialist, and they felt otherwise. And so on a Monday morning, I got up, I ran 6 miles, I went and did another CT, walked into a pulmonary specialist office and was told that I had lung cancer, which I promptly told them was an EMR error, malpractice, and I did not have lung cancer. I explained I had sweaty hair. My dad's a lung doctor. I've never puffed a cigarette and I'm fine. And he just kept looking at me saying, I understand that you don't think you're the picture of a lung cancer patient. I understand that you don't smoke a cigarette, but you have lung cancer. So that was a Monday, and I'm really lucky I did that scan because Tuesday the bronchoscopy came back with the adenocarcinoma, highly invasive cancer cell type. Wednesday in the pathology report. And after seeing the surgeon on Thursday and the nuclear medicine doctor for a PET scan Friday, they moved my surgery to Monday morning. So I only knew about my lung cancer for a week. They were nervous that it was so invasive. But again, I'm really lucky I did that scan and lucky that I can be here today as a survivor and a thriver. And, it hadn't spread to my lymph nodes. I had clear margins when they removed half my lung. And within 6 weeks, I was back to my 6 mile running loop. And this was just this past October, and in Thanksgiving and in December, I was back to skiing at 10,000 feet. So I caught it, I think, just in the nick of time and had the right, medical care around me to support it. And, was lucky that my husband pushed me to get the scan. And now I'm on a huge mission, Samira, because lung cancer is killing more young, healthy women than breast cancer and ovarian cancer and colon cancer combined. No one's talking about it. And I want other people to get the scan too.
Yeah. Shira, one, I'm sorry that you went through what you did, but I am also a little selfishly grateful because, and tell me if I'm wrong about this, but I think privilege plays a big part of getting good care in the US. Right?
Yeah.
Had you and your husband not been curious to get a scan that is not recommended medically, the medical community is actually somewhat pushing back on, is discouraging of, becomes the conduit to you catching something super early, I think is a marker of having access in a way I think a lot of people in this country don't. And I personally went through a lot of things that allowed me to have the outcomes I have because of privilege. And I would love for you to maybe take a stab at talking about that a little bit.
Yeah.
And how that factors into what you're trying to do now.
You're right. It is 100% because I have the right connections and the means to take care of everything within just, days and weeks time. Part of what I've started doing from the very beginning when I realized this is that I found that cancer doesn't care. It doesn't care if you have money or don't, or what color your skin is, or how many kids you have, or your age these days. And so I started a fund and a foundation in partnership that's called the Cancer Doesn't Care Fund. And you can learn about it on cancerdoesn'tcare.com. But the whole, auspice behind it is that it's not fair that I could pay for the scan out of my own pocket and others can't. So all the profits from my book called One Scan Saved My Life go to the foundation. And I'm working to raise money in other ways as well. And the idea is to pay for people's scans that can't afford it. So ultimately, for, let's say, the breast cancer space, we get mammograms starting at $40, and Medicare and Medicaid and insurance, private insurers are paying for that. And that's what I would love to see in conjunction with the mammogram, but a low-dose chest CT for your lungs. And until we can get Medicare and Medicaid and the private insurers to cover it, my fund, Cancer Doesn't Care, is there to pay for that scan. I also started working with individual facilities that administer the scan, and I've been really successful at lowering those prices. So one of the things I did is, if you go on cancerdoesn'tcare.com's website, you can put in your zip code to find the nearest one near you. You can call them and ask how much their pricing is. I've learned that if you say that you do not have insurance, it makes it less expensive. I've worked with, for example, Vanderbilt. My first test was $777. I had it down to $450 by January, and now it's just under $200. So I'm also working with them on that, so that if you can't afford a $770 scan, or you can't afford a $2,500 MRI, I understand. I've gotten it closer to $200, and other places have been, even lower than that. And so I think there's two sides of it. One is to cover people's scans, and the other is to just work with these, groups to lower it. We've found, actually, I had some of the private insurers do some backdated look at their claims, and they found that actually if they paid these $200 scans for all their members over a certain threshold, age threshold, or, risk threshold, that it was not only saving their lives, like for me, but it was saving money too. So we're kind of working, on both sides. So from the bottom up to pay for individual scans, and the top down to get it covered.
That is incredible. I think a lot of times we actually need system change to get to where you want us to get to, which I agree with. And I appreciate all the work you're doing at the ecosystem level, because I think you're spot on. I think unless finances come under control, I think moving the needle on screening becomes really, really hard. I think there's a second piece, and I'd love for you to talk about it, though, in lung cancer in particular, is stigma. I think a lot of people still believe that lung cancer is a smoker's disease, right? And we know that that's just not true. But there is this cultural narrative around that. And then, on the off chance you actually get lung cancer, there is an additional level of like, oh my God, even if I'm not a smoker, everybody believes that this is a smoker's disease, so I'm going to take on societal stigma. Can you talk about that a bit?
Yeah. So it's interesting, Samira, as a breast cancer survivor, I'm sure when you told people, oh my gosh, I was just diagnosed with breast cancer, people probably were like, oh my God, how can I help? Can I make you food? Can I pick you up? Can I drive you to your appointments? Can I,
Yeah.
do all of these things? How did you find it? Where did you find it? Things like that. It's been interesting for me. When I tell people that am a lung cancer survivor, they say, oh, I didn't realize you smoked. And I always say, oh, okay, you've known me for 40 years. You know, my dad's a lung doctor. You think I'm hiding packs of cigarettes from you and you've never noticed? I mean, the reality is that the smoking cessation campaign was so successful that people started saying, if you smoke, you get lung cancer instead of if you have lungs, you can get lung cancer, And I think the stigma around it is tough. I think that if you do smoke, it's not your fault if you get lung cancer. I hope that you can get your screens and take care of yourself. It is very and highly addictive. It's not, it's an addictive drug, alcohol. There's so many. It's not their fault. And so smoking individuals shouldn't be penalized for it. They should, not be, shunned or looked down upon. And then the other side of it is, like I said, if you have lungs, you can get lung cancer. So we should pay attention. There are other risk factors. So for me, in my lung cancer, we haven't figured out what my risk factor was. I mean, I have it. It's clear. My book, like I said before, One Scan Saved My Life. They actually put a picture of me on the front of the book, and I was very uncomfortable with the publisher in the beginning. And he said, no, we need your picture on there. You don't look like, somebody who has lung cancer. And I realized you're right. I'm not the Marlboro man with like the black coal lung. And I think it's a tough, view to see. A young 40-something-year-old woman with 4 little kids is the one that's getting lung cancer. The reality is that the United States Preventative Services Task Force has put guidelines out there, which Medicare and Medicaid and the private insurers follow, that says if you're over the age of 50 and you smoke a pack a day for 20 years, we will cover your low-dose chest CT. Well, the reality is that if you are an individual who's over the age of 50 and smoked a pack a day for 20 years, because of the stigma around smoking, a lot of those patients don't tell their doctors the truth. They don't order the low-dose CT. They're finding actually less than 20% of people that meet those guidelines are even getting the scan. And sometimes I think if we drop those guidelines to be over the age of 40, period, or like a mammogram or some of these other low-hanging fruit, if there's a family history, if it will help increase the number of people that do get scanned that are the smoking individuals, as well as increase the number of other people, because they'll be sitting in the hospital waiting room to get a low-dose CT with other people that they're not as uncomfortable to be around. It's not as much stigma. When I was doing my research, Samira, I think I told you this before, breast cancer survivors have a 2-fold increase of getting lung cancer as a primary cancer within 5 years of diagnosis, not because of radiation or treatments, nothing else, just, lightning striking twice, bad luck, breast and lung. And I think that if we realize that and we see that in the data and we add that, it'll help with the stigma. It'll help with the stigma for people like me who don't smoke and end up with lung cancer, and help with the stigma for people that do smoke and should be screened for lung.
How have you personally managed to address the stigma with friends and family, right? Because education for broad population is one thing, actually grappling it with your immediate circle or your secondary circle, I think has a slightly different flavor to it. I'd love for you to talk about that if you're comfortable.
So I think when I went down this whole process and realized that I had lung cancer and had half my right lung removed, and then was learning more and more about the disease and realized that we needed to make a change, I kind of like tried to take the 10,000 foot view and say, in a perfect world, what would I want? And I think in a perfect world, I want all cancer to become a chronic illness, something we die with, not from. And I think we've been really successful, not 100% of the time, but the numbers are going up in the breast cancer space, for example.
Absolutely.
We're screening for it earlier. I have so many friends who are breast cancer survivors and thriving and doing great. And it's because we catch it early and we can surgically resect it. Maybe we go on some sort of a chemo or radiation targeted therapy, but we're beating it. And I look at my own mother, who's a breast cancer survivor, and she's been, cancer-free for 24 years almost. And she is doing great. She's in her 70s. You wouldn't know. Everything's wonderful. And she's thriving. And when when she comes her term to pass, it won't be from breast cancer. It'll be old age or one of these others. And so I think if that's your goal or my goal, I had to step back and look at it and say, okay, there's two avenues, right? There's the top down where we need to change policy. We need to change insurance coverage. We need to, figure out what's going on there. And then the bottom up, we have to educate people. We have to educate the doctors and explain to them that it's not just people that smoke cigarettes that can get lung cancer. And we also have to educate patients, because I think the most important thing for people like me and for you is to advocate for yourself. When you know something's not right and you know something's off, or you're trying to figure out what's going on, or you want to get that low dose CT or the mammogram, the doctor's not going to come knock on your door. You have to get up and make the appointment and figure it out yourself. And so when I looked at both of those ends, I wrote the book so that I had like that anchor for it. So that if somebody pushed back and said, no way, you obviously smoke cigarettes and don't tell people the truth, or no way, you have another, high risk factor, I can hand them the book and say, look at the data in here. You could be a breast cancer survivor. It could strike twice. You could be, any of these other things, and it would be there. And then also from the top down, it kind of gave me a little bit of validity to walk in and talk to them about it. So the United States Preventative Services Task Force, which we talked about before, that sets the guidelines, they need data, they need research, they want science, they really want a full and all-encompassing view and picture. And I agree, we should use science and research and all of it. But I think what's interesting in today's society with AI and with these claims data, and the fact that a CT scan of your chest doesn't go away. It's not blood work. It's not, tumor tissue. We can look back on that data from the insurance businesses and Medicare and Medicaid and see it. I think some of the pushback we get from doctors, as well as, administration like the CMS and HHS, is a fear that there's like the rabbit hole we go down, or the false positive. And I often say to those doctors, in my wildest dream, my lung cancer would be a false positive. So please, yes. Wouldn't you like the breast cancer to be a false positive, Samira? And they're like, well, that's not fair to say. Well, you're not a cancer survivor. So telling a cancer survivor that it could have been a false positive would be our dream, right? It's crazy.
Absolutely.
But I understand they don't want people going down rabbit holes. They don't want people having half their lung removed and it not being lung cancer. They don't want you to have a double mastectomy and reconstruction and then it not being breast cancer, right? There is an answer and a reason for what they're trying to portray in their false positive, even though we would all love a false positive. And so I think the response to that oftentimes when I speak to doctors or the administration is, I get it. We don't have the capacity in our health system for everybody to get a double mastectomy or a lobectomy of their lung. But I think that AI and all of this data that we're getting today really helps that. So if you look at breast cancer, for example, they do the mammograms and the MRIs and the ultrasounds, and then they ultimately do a little biopsy to be able to say yes or no.
Correct.
So they can look and say, definitely not cancer, definitely cancer. There's this wiggle room area and we need to figure out how to, splice these patients to say definitely is or definitely isn't. Same thing with lung cancer, right? So when a radiologist looks at your lungs, they can sometimes say, definitely not cancer, see you in a year, see you in 6 years, don't worry about it. Definitely is. Or like, what do we do with these middle people? Because a bronchoscopy, which is a lung biopsy, is
Yes,
a lot more invasive than a breath.
absolutely.
So
For
how do we
sure.
do that? This AI and some of the data that we're getting in this new technology that's being discovered at lightning speed is going to help reduce that in between people, that we can easily push people to one side or the other. And I think that's my answer. And hopefully those indeterminate folks get a lot of false positives, and then they move to the not cancer section. And then the few that do have it, we can address it earlier. So whether it's AI wrappers on CTs, blood tests that look for floating DNA, things like that, that help us reduce that group of people in the middle.
That was very, very well put. So thank you. Thank you for doing that. Should we talk about loneliness, stigma?
Yeah, it is. You know, it's so funny. I've latched onto a lot of my breast cancer survivors. So maybe that's what I did, Samira. I was like, oh, good, breast cancer survivor. Got you. Because being a lung cancer survivor is really lonely. There's just, unfortunately, not many of us. So, like I said at the beginning, lung cancer, if heart disease is the deadliest disease in the country and cancer being the second, lung cancer is actually the deadliest among cancers. And any way you splice the data, any 2 or 3 cancers, their mortality rates are lower combined than lung cancer. So I often talk about the women's health crisis side of it, and it's killing more young, healthy women than breast and ovarian and colon combined, or breast and ovarian and cervical combined, or whichever ones you want to address.
Yes.
And the reason for that is because we're not catching it early, like we're doing with breast cancer. If you catch lung cancer stage 1, it's a 90% survival. You catch it in stage 4, it's less than 10. And the reality is, with breast cancer, we do mammograms and MRIs. We can feel lumps and changes in our breasts. We actually don't feel our lungs at all. So oftentimes people say to me, what were your symptoms? And I say, I didn't have any. They're like, were you coughing? No. Were you short of breath? No. I ran 6 miles the morning that they told me. Your lungs compensate, so they just take in more air. They don't grow bigger. They just use the healthier part of your lung. You remove half your lung, the healthy part of your lung just takes in more air. Our lungs also have no nerves, so we just don't feel it. And the reality is, if you don't catch it by luck on a random scan, or hopefully one day on a random scan that insurance and Medicare and Medicaid cover, if you don't catch it like that, you catch it once you have a symptom, it's too late often. So lung cancer spreads usually to your bones in your brain first. And so oftentimes you can be on a run and your hip hurts and it's lung cancer in your bones of your hip, or your vision gets blurry and they find lung cancer has spread to your brain. And so the reality is, as we sit today, the medication that we have is just not as strong as others. And the best chance of survival for a lung cancer patient is early detection and surgical resection. And that's the reality of it. I think that's the case with a lot of cancers, right? Breast cancer is better if you catch it stage 1 or 0 and you get it surgically removed. Colon cancer, if you can get those polyps easy and out quickly. So it's the same game. We just aren't catching it early because we're not screening or looking for it.
Shira, is there anything I have not asked you that you would like to share?
I just want people to go get their low dose chest CT. And I think it's important. And I know it's expensive, $200
Yes.
usually. You can afford it. You're going to have to fight your doctor to order it. You can go on my website and it'll explain to you how best to get it from your doctor. But that's what I want. I want people to get a low dose chest CT. The other thing I would say, when you do get that chest CT, just not to scare yourself, because lungs have nodules like skin has freckles. So what we really want is a baseline chest CT, just like a skin check, so that you can then come back 3 months, 6 months, 3 years, 6 years and say, oh, nothing has changed, or that nodule grew. Just like, a freckle or a mole that doesn't change doesn't matter anything. But if it does start to change, it's when you have to pay attention. So my big takeaway from people is to go get a low dose chest CT and your mammogram and your colonoscopy and all the things.
Shira, thank you.
Thank you, Samira.
I consider myself relatively well-informed, but I think I walked away having learned a lot of different things about screening for lung cancer. So thank you for sharing your wisdom. Thank you for doing what you do. And we will link to our website so people can find you when they listen to this show. So thank you, Shira.
Thank you.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of MantaCares Inc. or MantaCares' sponsors.